and the patient is actually moving through the continuum much faster. So we need better access to information to make sure the patient, as you said, at the right place at the right time.
Hi, this is Unlimited Access. My name is Levi.
Hi, I'm Shannon.
And I'm Ulrike Berzau.
We've had you on before. Can you just do a quick other reintroduction? I think last time I introduced you as a healthcare researcher, and that is not quite right. There's so much more to what you do. Okay, can you just reintroduce and give us your background?
I'm a healthcare consultant, and for most of my career, I've been leading rehabilitation services and rehabilitation hospitals. In Boston, I worked closely with the Harvard physicians. Then I also did a lot of international. I'm doing a lot of international consulting in the Middle East, in Canada. And I'm also teaching at the university. I teach in the public health and the public administration programs.
So your background, you've been doing this for some period of time, and I don't want to date it because that way it ages us, right?
As the oldest, every time we do that.
As the oldest person here in the group, as the grandfather, I'll take that. With your background, you saw something in what we're doing here at Ursamin, right? And I think we've all kind of are really excited about the potential of how we could, I'm going to say the word on my end, radically change the healthcare industry. From your perspective, let's jump into the continuum of care, right? And I'm going to try to define what I think continuum of care is, and then I want you to see if you can help me articulate. But continuum of care is I got care at the emergency room, right? And then once I check out of the hospital, I don't leave that care cycle, right? There's probably some follow-up. There's some things that need to continue to happen until I'm completely healthy. Is that a good way to define continuum of care?
Definitely. And it depends really why you were in the hospital, why you went to the ED or the hospital in the first place. Let's say after a traumatic accident. You will have a lot of rehabilitation needs, and the continuum of care has multiple different levels of care. It could be rehabilitation, it could be inpatient, it could be a skilled nursing facility, home health care, could be outpatient rehab, and then of course you need to follow up with your physician or mental health provider. So there are so many different pieces in the continuum of care, and part of the continuum experts is to make sure you are actually at the right level of care. And in order for you to get admitted to the right level of care, we need the appropriate information. And right now, everything is very fragmented. We need to find the information at the acute care hospital and maybe your primary care physician or other providers. So having Ursamin as a platform helping us to have the information really coordinated, streamlined, and all together in one place would be a significant advantage.
It's as you went through that continuum care of the levels and saying, making sure you're in the right place at the right time, it reminded me of a question that Levi asked me, which was, how has it changed in the last 20 years? Why now do you have such a hard time with that continuum of care? Except for at the time we were talking about care coordination, and we said as a patient, listen, 20 years ago you had a primary care and you might have a specialist or two. Now the average is 6 to 12, six average different people, and then different levels of acute care. So I would assume, based on what you're saying within the medical community, and that's why it's great to have you guys join us and say, this is from our side, how the processes have changed and how many more people we have to talk to help you as a patient manage through that. So 20 years ago versus now, what are some of the main differences that you're like, it's just made it so painful?
And you're bringing up a really important point, because 20 years ago, a patient stayed much longer in the hospital. So it was, let's say, the hospital care and the physician. So there was not such a need for... Exactly. And there were like main providers, hospital and your physician. Now there are so many different levels of care, and the patient is actually moving through the continuum much faster. So we need better access to information to make sure the patient, as you said, at the right place at the right time. And then we can provide the right care to get the optimal outcomes. And that is all actually done in a very speedy manner. And insurance push the patients through the system there to save healthcare expenses. You want the patient to move through the system faster. And also
the patients over here and the doctors over there, like, somebody's got me over in a different building. That's why you keep, oh, okay, that's interesting. And it makes me think about, remember the transition of working in an office together to remote working. And there's a skill set involved in managing a remote team. And there's tools that we have all given. I've been remote. I started working out of my house in 2003, maybe 2005. And there's a huge transition to not have the conference rooms, the team approach, the conversations that you could have, like you're saying in the hospital. Now it's like everybody's remote and you got to facilitate that communication. And this is what I was saying before when I complain about, hey, there's all these breakdowns because you've got so many points of failure now that you didn't have before of that data flowing, that nobody really thought about that when they built the original plan for how do we set up policy and for meaningful use and sharing of data and privacy. Nobody thought that you were going to go from 5 touch points to 15 because we're moving more and more outside of the hospital. And you're right. I feel like everybody I know who goes in to get an operation and they're getting kicked out like within 12 hours, they're like, wait, I'm not ready to leave. And they're literally kicking you out of the hospital before you're ready. And everybody's like, no, we got to get out of door to the next facility. So really interesting insight. Thank you. That was
and the throughput is so much faster. On the other hand, there's a benefit of bringing the care more to the community because you're really bringing the care to the patient where the patients are. Yes. And from the acute care hospitals to the whole continuum of care, that includes also, think about during COVID, your vaccinations, and now pretty much all your vaccinations you get at Walgreens or any kind of pharmacy. I don't want to endorse here any pharmacy, but you get it in your community. It's like 2 minutes away. And for that, wouldn't it be amazing when the Ursamin platform is shared with all providers, so someone at the pharmacy can access your records as appropriate, and someone in the hospital, the physician, the post-acute providers, the home care, and your medical equipment, everyone can, with the appropriate confidentiality and security guidance, can access the information. And then when you go to get your vaccination, you only need to say, okay, here's my information, here's my Ursamin, and off we go. Your vaccination, your booster shot or whatever it is entered in the system, and your primary care doctor knows. And if you need any other follow-up, everyone knows you had your booster shot.
Cool. I love that. That's really just a whole different perspective. That's all I can say. I don't have anything to add to it, Levi. I said, I'm just here. My whole brain is going to, I'm already thinking operationally, imagine, and that's what I always do. Imagine all of a sudden you've got an assembly line. And my vision right now is of the patient in like a wheelchair being shoved through the 7 layers of the healthcare system. No idea what's going on because you don't understand all this stuff. And now I think about my mom and how confused we were. We just were always confused. We had no idea what was going on. And it just is, oh, that's what happened. That's what happened. So,
and really, we are talking about the different levels of care, but the key provider, or not provider, the key person here in the whole puzzle is actually the patient. Imagine how powerful it is when the patient actually can be part of the care. So the care is not done to the patient. No, it's done together with the patient. The patient has access to the information. The patient knows what's going on. The patient knows the appointments, the medication, and has also education. And I know Ursamin platform provides education. In addition, also, many patients do have a caregiver because especially those with disabilities or aging population, the caregiver is taking care of all the different needs of that person. And it's to keep track of that. And I know you, from your mom, you had to take care of so many different things. It's really overwhelming unless you have it in one place and you get some really tools and strategies to take care of that.
If everything in this continuum of care is, I'm saying everything is in terms of information, right? It's all accessible. Isn't there a challenge with information redundancy, though? The idea of like my blood pressure if I've got it listed in 15 different places, this information redundancy, maybe even saying 15 different places, maybe the same place listed 15 different times. What are some of the things that can negatively affect patient outcomes when it comes to this information redundancy?
So information redundancy is number one, an administrative burden, that there is so much time spent in figuring out how to enter the information, how to find the information. And then when there's redundancy and the same information is in multiple places, there's a huge error rate. Because when someone has to transcribe, let's say, your blood pressure from here to there, they might just forget a zero, or it's maybe not legible. Now with computer, thankfully, most of the stuff is legible. But still, I remember when we go to like different physicians, we still fill out things on paper. It's just mind-boggling that why we have to fill out the same information over and over again and always on paper. And then someone has to transcribe that and put it in the computer. The error rate is huge. It's redundant, it's time-consuming, and a high error rate.
Yeah, it's. I think the other thing, and we talked to Julie, Dr. Julie Shapiro, a few weeks ago, and one of the other things that she said, and you probably felt that, I'd be curious to think if this happens like in the rehabs as well, is she said not only the error rate, the user entry error, there's just so many, again, there's so many points of failure. On the technology side, we always said points of failure. You want to limit the points of failure. If you want a 99.9999% uptime network, you have the least amount of points of failure that you can control. But in healthcare, she was like, listen, part of that also is the noise level. And I'm thinking noise level because I'm posting today on LinkedIn for anybody who wants to see my Friday rant, is I got an email from my doctor that says, hey, you have a message. And I get these all the time. Hey, you have a message. I open it up. Hey, we're now wearing masks in our office. Superfluous, unnecessary information that just gets sent out to me because they're checking a box. So the next time I do get an email, I don't read it. It doesn't say, hey, you've got a really important, it doesn't prioritize that information. It doesn't tell me hey, you've got an appointment coming up. Hey, hey, there's some really good information. There's no priority. It's just pushed. And that's what happens to the doctors as well. And so when you get redundant information on top of already not organized information, and that's where we're like, listen, it's one thing to have all the data. And our lesson learned in the first year was not everybody wants it all. The problem is they have too much and they can't get to the data that they need. So our real value is what that role that I played for my mom, which was sorting through 15 pounds of paper to find the information that particular doctor needed. And if I can automate, that's going to make doctors like, oh my God. And that's what Julie said in the ER. I've got a very small amount of time to triage this patient, and I have to get this patient in and out a door. And she goes, and then you try to find it. And by the time you get to it, somebody interrupts you and you're off. And she goes, and you're exhausted by the end of the day. And that's why we're overloaded. We can't get patients out of the ER because of this bottleneck of duplicative information that isn't getting filtered because everybody's just checking a box and sending it. And they might send one doctor might send you the same data that somebody else is sending you. And then that receiving doctor has to filter. And no human can stay up with that amount of filtering.
And for the patient to have one point of access, or for the healthy person, just for preventative care, have one point of access, finding what I need to know, where I need to go, what is my next step.
Yes.
That would be so helpful. Most people don't take part in the healthcare decisions because they don't know even where to start. There's too much information. There's too many different portals. Most people don't know how to log into the provider portals or the hospital portals. And when they finally remember where to log in, then they forgot the password, and then they don't find the information there. And there's one information at the specialist office, different at the primary care office. So it's overwhelming, and especially for caregivers. As a healthy person or a patient, it's already overwhelming. But for caregivers who have to take care of someone else's health and wellness, mental, physical disabilities, all of that, it is huge. It's a huge task.
Is this task for people, the special focus for you specifically on disabilities? I think about myself and I just don't go to the hospital that often. If I do, it's for checkups and stuff like that. But with people with disabilities, right? So for the rest of their life, potentially they're having to manage this care. What would a unified platform like Ursamin do to help this?
So with disabilities, there are, of course, more comorbidities. That means someone with, let's say, a spinal cord in a wheelchair, there are more comorbidities, more specialty needs, specialty physician visits. Then, of course, there are a lot of needs for equipment, medical equipment. And then there are needs for AI, for assistive technology that helps the person with a different ability to be independent and functional and able to optimize their life. So for all of those things, to keep track of it, where did they get the wheelchair from? Where can I get whatever equipment they need? Where can I get this assistive technology? It is really, it's a huge task to remember where to get it from, and then also stay up to date. Maybe there's a better version, maybe there's something better coming out. And then, of course, the insurance, will the insurance pay, will they not pay? So all of that together is a significant overwhelming task for the person with a disability, for the caregiver, and even for the providers, for the physicians. When I was like, okay, so I don't remember, where did you get this from? Where did you get this from? And I heard about something better, and where was that? So having everything streamlined and together on one platform where the patient and the caregiver and the provider can communicate, and they can really together take part of the care. And it's not a one-sided thing, it's really a partnership, everyone involved.
And Shannon, we're talking about people with disabilities and patient care management there, but is it very similar for chronic care too?
Is it? I'm sorry.
Yeah. So for me, it's like the idea of disabilities, you use the idea of, like, mention this idea of a wheelchair, right? And so let's say somebody needs a wheelchair for the rest of their life. Chronic care, we're thinking about diabetes, heart care, et cetera. Isn't basically the same challenges that people have with disabilities, similar challenges with chronic care? And are there any differences?
Thank you. Yeah, I was like, for a minute, I was like, I just was not processing it again. Friday, gotta love these Friday events. Yeah, so I'd say there are similarities and there are differences, and it really comes down to which groups are more urgent at different times. And that's where some of the things that we're talking about is the care pathway, and where do we fit, and where are we most helpful. I got 3 more notes this week, by the way. I always say this. I yell about everybody saying, don't say records, because we're really trying to solve this problem called health management. It's an operational problem for everybody. And so I keep evolving that. That's why our mission statement is we're always working on that. How do we tweak it a little bit more? But I just got 3 notes this week that said, I know you talk about caregivers a lot, but let me tell you, I just broke my foot. I was in the hospital. We're going to do a testimonial on her. She's like, listen, I couldn't remember my medications, fluke injury, going through hospitals, getting pushed through, and nobody's got stuff. I can't remember. I feel like crap. I don't got anybody help me. I don't know where my stuff is. Please focus on patients, Shannon. Please focus on patients. I'm like, we've evolved from caregivers to the whole group. And then each person has a different story, diabetes, disabilities. It is the same problem. It's where can we intervene and bring value at that stage? I don't know enough to say that I can say it's better or worse. I can tell you that where we find people really valuing, and I shouldn't say desperate, but you're desperate for help, is when you're in a high comorbidity situation. I'd say for parents with disabled children, very big problem, but their pain is a little different because they're financially strained, where we help on the healthcare strain part. So it really comes down to, yes, they're very similar in that they're long-term lifestyle financial changes that you have to make to incorporate that new thing in your life. Sense of urgency might be the healthcare side or the financial side. Our goal eventually would be, we're just talking to this about one of our mentors, is partnering with a fintech, financial tech organization who's helping address that financial strain for caregivers, patients, and providers. And now you've got this really cool medical financial combination, because that's one thing we don't talk about is not only the information on your health, but will my insurance pay for it? How much is it going to cost me to get this care? My mother had cancer treatments and couldn't afford it. We were looking for foundations. I try to do some of that financial stuff. We don't really talk about it because everybody likes to talk about the medical records, but I'm like, what about the financial support people need? So it's a long answer. I'm learning that I get too verbose, right, Levi? But the short answer to that is, yes, they're very much alike. The question is, what is the pain point that they need to solve? and can we help them there? And that's where I think we have to understand a little bit more of the differences. And now you've got a follow-up conversation we need to have, Ulrike. Now you just gave yourself a homework item. Guess what?
And the more complex the care needs are, regardless of disability or of chronic needs, the more complex, the more overwhelming it is. Because the more complex a person's care needs,
emotionally,
exactly, and the person is already overwhelmed with their own care needs, and then the caregiver and yes, the financials are driving often the care. Especially in the post-acute setting, the continuum of care. Will my insurance pay?
Expensive. It's expensive. Like even my PT for my back, it's, you're like, oh my God, I got to pay $50, $75 twice a week.
The way I look at it to summarize this show today is this idea of like, we're really empowering the patient. And whether that patient has a caregiver, doesn't really matter. It's this idea of like patient is just going to have access to all of their information. And they're going to be able to make better informed health decisions. Their caregiving group, the physicians, the nurses, everybody involved is going to have all this information that's readily available so they can have
you got a buy-in, right?
Better health.
Yeah, you got a team that's working together on the same plan, and the patient's part of that plan versus, I don't want to say a victim, but a non-participant in that plan. The plan's just being pulled along. And that's where you really want that patient to be invested in their own plan, because it's proven over and over again that you get higher success rates. So give them the data, give them the information they need to feel confident that plan's going to be effective.
Thank you so much for coming on our show again. And I hope there's a part 3 and a part 4. and
maybe we'll start doing 4. Maybe we'll start doing ones with 4 where Ulrike becomes another facilitator. And now it's 3-on-1. We're like, okay, let's ask them questions.
Yeah. Movie 2, right? It'll be like a team sport.
Yeah. Doubles.
Again, thank you so much. And here at Ursamin, we believe patients, people, everybody, when they're empowered with all of the information, they make better health decisions. And that's what we're hoping for here at Ursamin. So thank you so much for everyone, and goodbye. Thank you so much.
Bye.